From the American Academy of Pediatrics.
As many as 10% of children in the United States have food allergies.
An updated clinical report looks at the management of these allergies in schools.
Most schools these days have managed this before, and they do have things in place to be able to appropriately recognize and treat if there was an allergic reaction.
Plus, the 9th edition of the Neonatal Resuscitation Program, or NRP, offers new approaches to treating our youngest patients.
There is nothing like being at a birth where the baby comes out gray and floppy, and your team knows what to do, takes the correct steps, and the baby does great.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians, for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a discussion about the management of food allergies in school. Joanna, I know that after we interviewed Dr. Julie Wang recently about anaphylaxis, you began to worry that your son Simon might be allergic to peanuts. What have you learned?
Yes, and for our listeners, he said that he got this tingly mouth sensation when he was eating them and that it felt like he was eating a bunch of thorns. And this is truly a case of the podcast helping me because as a neonatologist, I don't think about food allergies. And I have now learned a lot about them, though, through Simon's diagnostic journey. His skin test was positive for peanuts and his IgE levels showed some concern, but the component testing wasn't a slam dunk for anaphylaxis to peanuts. Anyway, we have a food challenge test in November, and we'll have some more answers then. And our podcast family will be the first to know about those results.
Well, I am waiting with bated breath to find out what you find out, Joanna. And I have to ask, Simon's starting school this year. Does that make you nervous?
Of course. We've had to do some new things like have an allergy action plan and get EpiPens. And I've been in touch with the school nurse more than usual. And I'm a little on edge now about exposures.
Well, then I hope you'll find some reassurance from our next guest, Dr. Scott Sicherer. He is at the Icahn School of Medicine at Mount Sinai, where he's the director of the Elliot and Rosalind Jaffe Food Allergy Institute.
He is also lead author on an updated clinical report from the section on allergy and immunology and the Council on School Health called Management of Food Allergies in Schools. Scott, welcome to the show.
Thanks, Joanna. Thanks, David. I'm happy to be here.
Scott, I think you heard that my son was just diagnosed with a presumptive peanut allergy. How common are food allergies now and how severe do they tend to be?
Well, it's been estimated that up to 10% of children have food allergy. And, unfortunately, it can be severe. Anaphylaxis is a severe allergic reaction. Fatalities are rare, but you can have quite significant reactions. So it's important to understand, to get the right diagnosis, to know what to do, and to stay away from the food. So lots to learn.
And I know from my own recent experiences that making a diagnosis of food allergies can be tricky. Can you briefly review how we know when a child has a food allergy?
Well, Joanna, you know about the nuances there. And, you went from, I saw a symptom to I got a test to wait, that test isn't definitive. Now I need to have something called an oral food challenge, which is sort of jargony medical terminology for a medically supervised feeding, which is done gradually. So, that's the definitive test. It's sort of the proof is in the pudding, almost literally. Like if you can eat the food, you're not allergic to it. But the long story short scenario is kind of what you said, which is that it's not just a test. I mean, the medical history is the most important thing, as I hope all of our listeners would agree. And getting a very detailed history is very important. I've had scenarios where a child might have had a reaction, let's say, to peanut, but they're eating, other foods in the diet. They're having egg, they're having soy, they're having milk. And then someone sent off an allergy test that tested all the things that they were already eating. And there were some, slight positives here and there on that quote unquote panel test, which led the family to get completely nervous and a wreck about the foods the child was already tolerating. In my world, that child already passed their gold standard feeding test to all those other foods. And now they're in extreme stress and anxiety that something bad is going to happen if they give their child something that they were eating the day that they had the test done. So, that's a panel test that shouldn't be done that way. It does feed into my biased comment to say that if you're suspecting food allergy, you probably should find a board certified allergist to really do a full workup. But nonetheless, these, I'll call them accidents, happen. The test is not like a pregnancy test. Pregnancy test is like, you're pregnant, you're not pregnant. It's not like, well, there's 35% you're pregnant. And so these tests, though, are more statistical. And so if your prior probability is like 0, in other words, I'm sitting there eating peanut butter, and then the test says there's some activity on the test, well, the answer really is you're not allergic. On the other hand, if you have a story that you gave for your child and there was a problem, then the test starts to support what that history is. And honing in on it further, there may be significant allergy or not, or maybe someone's outgrown an allergy and they still hold on to a positive test. It's really important because we don't want someone going to school worried, carrying their medicine, telling everyone what they can't eat when it could have turned out that they could. Plus, there's nutritional complications associated with not eating food unnecessarily. And, there's nutritional and social, right? Because now you can't eat, what everyone else is eating and you could have been. So lots of good reasons to get a really careful diagnosis.
And once we get this diagnosis, what information do we need to provide a child's school when we think a child has food allergies?
So the information that the school is going to want is essentially at its basic point, authorization that is saying that this is a child who does have allergy to X, Y, or Z, and authorization to treat if they were to have an allergic reaction at school. That's sort of the basic, an allergy and anaphylaxis plan. That plan typically has a signature from the physician, a signature from the parent. It has information about mild versus severe reactions, and about giving epinephrine, when to give it, about giving an antihistamine for comfort care. We could get more into those, but that's sort of what the pediatrician might be handing to the family to hand to the school just to notify them. But, school management of food allergy is way more than one piece of paper.
And I remember from my outpatient practice that forms differ from one school system to the next, but what information should be on every child's allergy and anaphylaxis emergency action plan?
So it's almost a shame that there are so many versions out there. The American Academy of Pediatrics has put together a clinical report that actually has instructions about and an allergy and anaphylaxis action plan itself that is widely available, but not every school is using that. And there are other organizations and other, sources of these kinds of forms, but these plans should be showing the authorization, should be showing what foods are being avoided, showing what symptoms are there and what the responses would be, the medications and their doses, the weight of the child. There might be information about whether they have asthma or not, because kids with asthma might have a more dramatic reaction if their asthma is active and such. There may be information there, depending on the school, about whether the child can carry the medication or not. There might be instructions on how to use the device, although I would argue that if you have to read a piece of paper about how to use the device, you're not in the right scenario. And it may have contact information about the family and the doctor. So there's a lot that's on that one page, but it's really important, to at least have it personalized, that the school knows that this is an individual that really does need this extra attention and understanding.
And is what you described an individualized health plan or a 504? What are these different plans that people could have?
Yeah, that's a great question, Joanna. I'm glad you asked. For most children, I think that the school is going to expect the paperwork that's saying the family did their due diligence, they have a diagnosed food allergy, so that's on this piece of paper, it's indicating what they're allergic to so that they know that that's verified by a physician. And it has the general guidance of what to do in an emergency. But there are other things that, might be in a school scenario for a given child. An IHP, or individualized health plan, is basically a written plan between the nurse and the family that can provide what's necessary for this particular child who has a health issue. It's not something that I would say is typically needed for someone with food allergy, because the plans that we've already talked about are typically used, but it's available if the school and nurse and family think that it's needed. So, for example, don't share food, and think about this when you're having parties at school. You can't just, give everybody a peanut butter sandwich and things. So they kind of have that information. Then there's the 504, which is more of like a legal document. Children who have disability have rights. And so the 504 plan would make sure that the child can participate in everything like everyone else does. Now, would someone with food allergy need that? I mean, in my experience, almost none end up needing that because the plan is the plan. But if the family feels, or someone feels, the physician feels that the school isn't doing its part, and there has to be some specific thing that they should be doing that they're maybe not otherwise doing, then the 504 might come into play to make sure that that's done, because there's a legal right to make sure that that child could do what the other children are doing. So, if there was a refusal to substitute something for that child so that they could participate in a school project. So, they're making peanut butter bird feeders, but hey, this child shouldn't be making a peanut butter bird feeder. The family's upset, but the school wants to do it anyway. This would be a legal way to say, no, my child isn't doing a peanut butter bird feeder. For those who know what a peanut butter bird feeder is.
That's so oddly specific, Scott, that I feel like it must come from personal experience.
Well, like I said, I see it's like 24/7 food allergy, and I don't think I've done a single 504 plan in years. But if they are going to help a given child, then they're there. And I'm going to babble on for a second because I think this is a pearl comment from me, but it's really harrowing idea to send your child to school at all. They're not under your supervision anymore. Someone else is taking care of them. You're not going to see them for, a number of hours. But then if they have the medical thing like this, it's like, well, I was the one reading labels. I was the one making sure they didn't grab their brother's food. And now I have to trust someone else to do that. I'm freaking out. So I explain to families, instead of going in to a school and saying, my child has food allergy, here's a list of 200 things I need you to do to keep them safe. I suggest to families, go to the school with that authorization page, say to them, my child has food allergy. What are your policies, or what do you do for children with food allergy? And let them tell you what they do. And I think most of my parents are surprised that most schools these days have managed this before, and they do, have things in place to be able to appropriately recognize and treat if there was an allergic reaction. They've probably thought about this before, but if they haven't, then you have a deeper discussion.
And we know that when a student does have an anaphylactic reaction, epinephrine is life-saving. How many schools keep some on hand just in case?
I don't know the statistics on that, but there is a law about having access to epinephrine, and there's a state-by-state interpretation of the law, and then there's school district by school district policies. So unfortunately, I don't know the numbers on that, but that question brings up the idea that there are reactions that happen in school for people who don't have an identified allergy. That could be a teacher, that could be a student. So it's kind of nice to have stock epinephrine. In other words, a non-assigned epinephrine device. It is recommended by, these guidelines, because that would provide that measure of safety, kind of like AEDs, the defibrillators that are, publicly available. It's the same kind of idea. Like if someone has the need, at least you have the medication available. And yes, it's life-saving. And yes, that's the medicine to go for. And yes, if you decided to use it and you didn't need to, that's okay. I mean, epinephrine makes maybe be an ouchie, but what's the side effect? It might make you a little jittery, heart may go a little bit fast. Caffeine does that. Running around in the schoolyard can increase your heart rate. I mean, these aren't things to worry about. If you're not sure about giving the epinephrine, the idea is to go ahead and give it. You probably should have if you're thinking about it. It's a safe medication. I will throw in, and you mentioned that you spoke with Dr. Julie Wang, and I bet you that she, on a previous podcast, mentioned that some people think there's something dangerous about epinephrine because they remember a doctor saying to them, when you give this, go to the emergency room. And a lot of time families, do make that connection, even though the doctor didn't mean it that way. And so when would you ever go to an emergency room because you used a safe, effective, life-saving medication? I mean, that doesn't make sense. So the reason you're going to the emergency room is because you had a significant allergic reaction that warranted using this medicine. And because that occurred, and because symptoms might come back and they were bad to begin with, those are reasons to go to the emergency room. But that said, a second pearl for this podcast would be, when you're talking about using epinephrine with a family, don't villainize it. This is a safe, effective medication. In the olden days, they used to give it for asthma, like, hey, you're having asthma. Here's this injection. Wow, you're all better. Oh, it's 20 minutes. Your asthma's back. Here's another injection of this wonderful medicine that makes you breathe better. We don't need it that way anymore. But the lesson being that we don't want to villainize the epinephrine. It's safe, effective. Use it if you need it. It's life-saving. And by the way, if you're having a bad allergic reaction, you probably want to go to the emergency room. I will say that most schools kind of create policies that if they've used the epinephrine, they're going to probably be sending you to an emergency room, notify the parents and stuff like that. But that's fine.
Yeah, we should just caution people when they watch Pulp Fiction.
It's not that. Yeah. Actually, Joanna, it's funny that you said that because like nowadays you can't really find a family that hasn't already been familiar with self-injectable epinephrine. And now there's also a nasal epinephrine, but you almost can't find a family like that. But years ago, that was the great thing because like the families that weren't familiar at all, I was like, okay, look, it's not like Pulp Fiction. And they're like, oh my gosh, that's what I was thinking. So you're right.
And I'm happy to report that my son's school does have epinephrine in stock, so that was comforting to know. But I've also been reading a lot about banning allergens from schools or making certain classrooms nut-free. Do these strategies work to reduce severe food allergies?
So in the clinical report, we discuss what another guideline concluded, which was mostly about not banning foods. And some of that arguments with that have to do with just like, data about it. Does it really make a difference? Does it really reduce the number of reactions? Is there really an effect? But also because of potential social consequences. So like if you're like, oh, you can't have this in the school at all or in the classroom at all. And then, you start to like whisper, Johnny has a food allergy. And then someone's going to be mad at Johnny. Like, so there's all these things that, they made arguments about not recommending, but the evidence is not strong about that recommendation. And, the data are limited. In the clinical report from the AAP, we contextualize that. One of the things that the other guideline had open-endedness to was that, you could have developmental issues, you could have age issues, or other circumstances just around the school that would warrant having some types of quote unquote bans. Now, the word ban is hard to understand what we might be talking about without giving examples. I mean, there could be a school-wide ban on something like there's no peanuts or tree nuts in this school building, but yet, of course, people bring it in because, they do. There could be a classroom ban, maybe because that classroom has someone with allergy in it. But like I said, almost every classroom does. But maybe it's the classroom for, like childcare age or for kindergarten or a group that is able to not grab each other's food or something like that, or developmental issues in general. So then another kind of ban might be like a table in the cafeteria, which is excluding certain allergens. And there's one study that suggests that when that strategy was used, there was less use of epinephrine for allergic reactions with like having a allergy safe table. But again, that's just one example of a study. So anyway, that's the long version of the answer to these bans. I mean, it's really almost like a case-by-case basis. Parents might say like, hey, why not? I just feel better knowing that that's in place. The scientists might say, well, there's not a lot of evidence. It could be, counterproductive if someone says, oh, there's nothing here and then gives the food because their guard is down, right? It's sort of like, oh, gee, this whole place is free from the food allergens, so I'm not even going to read this label anymore. Go ahead and give this food to this child. So there's all different arguments on this, but that sort of summarizes what the different perspectives are and that there could be some case-by-case basis and also that some of the, expert guidances try to not go there.
Scott, what do you know about what's being done to ensure that school staff members are prepared to respond appropriately when a child does have an allergic reaction?
So, the clinical report talks about how essentially it takes a village. And, that village includes everything from, the dietary staff at a school, right? Because maybe the lunch is being made has to be done in a way that reduces, the risk of cross contact with the food allergen for the child, special meal situations. It includes, teachers who, have to know who has the allergy and what to do if they're recognizing something. If there's a school nurse, then, that's great. And they would know things. There should be some communication in the school. So, if something's happening in a classroom, there's communication that could easily be made to, let's say, a new school nurse or to an administrative office. If there isn't a school nurse, there should probably be people who are responsible for responding to an emergency like this. If there's an anaphylactic reaction, know how to use the medications. Ideally, every single person working in school would know how to do this. And there are some suggestions to have that be the case. What about the school bus? Craft projects? Does the teacher know about safety, about craft projects that might have food involved, having substitutions and such like that? A school trip, going somewhere. So, I'm kind of painting a picture where there are a lot of different subspecialty teachers, regular teachers, various kinds of school staff, so maybe even janitorial, because right, they're cleaning tables, so just like having elbow grease and cleaning products to get, the tables clean for the next set of kids who might have allergy or whatever. It is a complex process.
Before everyone goes out to read this clinical report for themselves, do you have any last takeaways?
So in terms of takeaways from the clinical report, and we covered, I think, all of these during this time together, a proper diagnosis is like super crucial. You want to know about the allergy. You want to make sure it's really there. An individualized written allergy and anaphylaxis emergency plan. I mean, that's key, that the allergist or pediatrician or primary caregiver is going to have to provide the school so that they know that the child has these allergies. It's helpful, I think, for families to understand that, the school doesn't want their child to have a problem. So they're going to, do what they need to do to try to keep the child safe. The primary route of exposure that triggers anaphylaxis is ingestion. And so although for younger kids, you definitely have to think about these craft projects and touching and sticking their fingers in their mouth and all these kinds of things, most of the focus should be on making sure the child's not going to eat the food that they're supposed to be avoiding. And then education about anaphylaxis recognition and management is very important, especially how to administer the life-saving medication epinephrine. Social aspects are really important. You want to make sure that the school personnel and even the children know about food allergy. Bullying happens when people aren't informed. And so it's like, well, this is so weird. Maybe I'll sneak some food into, my friend's lunch and see what happens, because it's so odd to me that I can eat this food and my friend can't. So understanding about the social consequences, bullying and such. And then there's very special things for young children, toddlers, babies and such, who can't really fend for themselves or watch for themselves. They need extra supervision, especially with meal times. And then adolescents are at special risk. Adolescents are actually the age group more likely to have fatal food anaphylaxis, albeit that it's rare. And so making sure that teenagers understand about being careful, informing friends, informing the school staff if they're having a reaction, and to have prompt use of epinephrine.
This was so wonderful to hear, especially with what I'm going through. Dr. Scott Sicherer, thank you so much for joining us today.
Thanks again. Thanks for having me.
To read Management of Food Allergy in Schools clinical report, go to aap.org/podcast.
Coming up, we'll look at updates to the 9th edition of the Neonatal Resuscitation Program.
David, last time we talked, you were preparing for a potentially challenging delivery. A mom had just arrived on the floor with no prenatal care. You had no idea the gestational age or anything. How did that wind up?
Fortunately, the newborn ended up being term, and he did great. But when we talked, Joanna, I was running through my checklist from the NRP, the Neonatal Resuscitation Program, making sure we had everything we needed for even the sort of micro-preemie that you care for all the time. And I'm so glad that our team drills for these events regularly.
I'm glad that was just a drill, but you're right. I'm using the NRP guidelines multiple times every day to make sure we do everything we can to take care of the sickest or littlest newborns from the moment that they're born. But aren't we due for some updates soon?
We are. And to talk about what's changing in the now 9th edition of the NRP, we have Editor-in-Chief Dr. Gary Weiner. Dr. Weiner is also clinical professor of pediatrics and medical director in the Department of Pediatrics Division of Neonatal Perinatal Medicine at the University of Michigan Medical Center C.S. Mott Children's Hospital. Gary, welcome.
Thank you, David. Thanks, Joanna. Nice to meet you.
I have so many questions for you, Gary, but maybe we could start right at the delivery with umbilical cord management. We know how we handle the cord can affect a newborn's hemoglobin and even chances of survival. What are you recommending based on the most recent evidence?
That's a great question. Management of the umbilical cord has been a really hot topic recently. We recommend for most newborn infants, certainly both term and preterm infants who are vigorous at birth, allow the cord to remain patent, so defer umbilical cord clamping for at least 60 seconds. In the 8th edition, we said 30 to 60 seconds. We're going to really encourage people to shoot for a target of 60 seconds. That doesn't mean it's the maximum. You can allow the cord for a baby who's vigorous and is on the birthing parent's chest to keep that cord patent for longer than that, but shoot for at least 60 seconds. And then for babies who are not vigorous, in 8th edition, we didn't really give you a lot of advice. In the 9th edition, if you're born between 35 and 42 weeks and you're not vigorous despite a little bit of stimulation, the option is to actually milk the umbilical cord from the placenta toward the baby 4 times, a length of about 20 centimeters. And that's called intact cord milking. And for babies that are late preterm or term, 35 to 42 weeks, there's some evidence that may improve outcomes. We don't recommend cord milking for babies less than 28 weeks gestation because it may be associated with adverse events. And the range of 28 to 34 weeks, we still can't exactly tell you what to do. Cord milking is an option, but we have not included it this time in the NRP textbook.
So, Gary, now that this cord is clamped, and let's say our newborn is still having a tough time, we've moved the baby to the radiant warmer, and if they're having trouble breathing, we usually start positive pressure ventilation. But do you have any new guidelines on this initial step of mask ventilation?
Yeah, we have some minor tweaks to the old guideline. When you think about ventilation with a positive pressure ventilation device, you think about peak inflation pressure, we've made a slight change to that. The old guideline was 20 to 25 centimeters of water for everybody. We're now going to give you just a single universal pressure to use is 25 centimeters of water. So the new one is 25 centimeters of water. But we've also given you a range. So if you're resuscitating a preterm baby, the acceptable range is 20 to 25 centimeters of water. If it's a full-term baby, 25 to 30 centimeters of water. But to make it easy for everybody, a single 25 centimeters is the new peak inflation pressure. And that's based on some research that showed it's likely will get you the tidal volume you're looking for. We've also made a little bit of change in the rate. The old rate was 40 to 60 breaths per minute. And now we've adjusted that to 30 to 60 breaths per minute. And there is some evidence that the slower rate in the range of 30 to 40 may actually provide a better tidal volume than faster rates. So we're going to try to avoid getting going too quickly with ventilation.
All right, I do love simplicity. But as a follow-up, I would love to address one of my greatest sources of anxiety during a resuscitation, which is getting a secure airway. In a year, I'll do about as many intubation attempts as Joanna does on a typical Tuesday. So any tips on establishing a secure airway for people like me out in the field?
Yeah, there's a couple. And I think one of them is to make sure that you know how to use a laryngeal mask and have them available. And in this edition of the NRP textbook, we've enhanced the attention paid to laryngeal masks. So now a laryngeal mask can be considered a primary airway. So you can use that in place of a face mask. There's a nice systematic review recently published that showed, in fact, laryngeal masks are more effective than a face mask and may prevent you from needing to intubate or start compressions. So if you're struggling with intubation, and now we know intubation skills are starting to decay across the country, new trainees just don't have that skill. So making sure you have laryngeal masks, know how to use them, and they're available is really important. And then consider using a video laryngoscope. For people who don't intubate very often, for new trainees, for people like me who are old enough that, getting that right focal length is pretty difficult through my progressive lenses. You're looking down a tiny little tube 14 inches away at this glottis that's open about 2.5, maybe 3 millimeters, and you're trying to get that in focus. So a video laryngoscope where you have a big, beautiful, bright, colorful picture on a huge screen in front of you is terrific. And we have good evidence now that using a video laryngoscope increases the likelihood of first attempt success, decreases adverse events during intubation, and it's terrific for debriefing. If you have trainees, you can record that intubation and show them how it went and give them some good teaching. When you coach with direct laryngoscopy, looking over a trainee's shoulders, it is really difficult. I can't tell what you're seeing. I can't help you. But if I can see if you're intubating as a trainee or someone who doesn't do it very often, I can give you really good advice as I'm watching the screen. So laryngeal masks, video laryngoscopy. We've also made a little bit of a change to the endotracheal tube size. And so now the size on the old table, we're making just a little bit of a tweak to. So now if you're under 800 grams, the recommended tube is either a 2.5 or a 2.0. And then when you go up, we used to break it by even thousands. And now there's a little bit of a change based on a study that showed people had to change out the tube during the first couple of days frequently. So now you get a size 2.5 tube up to 1,200 grams instead of 1,000, and a 3.0 up to 2,200 grams instead of 2,000. And those are kind of the big things for intubation now.
Oh, that is so helpful, Gary. And I'm going to start having my residents practice on LMAs more. Now I want to talk about ventilation and oxygenation. It's important to make sure newborns get enough oxygen, but we also worry about causing them harm from keeping the oxygen levels too high. How do we know how much is enough?
Boy, that has been a question now for decades, and it's really a vexing question, and we've been struggling with it. And the truth is, we still don't really know the right answer. We have made some changes to the recommended initial oxygen concentration now. We're still at this point recommending start with 21% oxygen for babies who are at least 35 weeks gestation. If you're in the range of 32 through 34 weeks, similar to 8th edition, we're recommending 21 to 30% initial oxygen, but target your oxygen saturation using a pulse oximeter placed on the right hand or wrist. And the target ranges haven't really changed. But it's important to adjust your FiO2 or oxygen concentration based on target sats. The change that has come is in the littler babies, in babies under 32 weeks gestation. And there is some evidence that if you don't reach 80% sat by 5 minutes of age, that may increase the likelihood of adverse events. We don't know that for sure, but there's reasonable evolving evidence that that's true. And starting with a higher oxygen concentration for small preemies may be important. In the 9th edition, what we've said is start with at least 30% oxygen. The thing that's going to frustrate everybody is we're not telling you exactly where to start. And that's going to vary quite a bit, I anticipate, across the country. And we don't know the right answer at this point. There was a recent systematic review published that suggested that starting with 90 to 100% may improve survival in babies under 32 weeks. At this point, I hesitate to tell everybody start at 90 to 100%. It seems reasonable, though, to start somewhere between 30 and 100% and at least target your FiO2 to meet the oxygen sat guideline. And again, you want to get to 80% by 5 minutes.
And I want to follow up on this idea of harm outside of oxygen. Sometimes I worry that my team could get a little overzealous with the suction and the chest PT during a resuscitation. How useful are these interventions?
Yeah, suction is one of those things that if you trained when I did, everybody had to have suction applied, right? You had to put that blue bulb in everybody's mouth and nose and suction them out. And many people would do what we called at the time deep suction. You'd put a Deli catheter down their throat and make them bradycardic from a vagal maneuver. At this point, we don't recommend anybody have routine suction. There is no benefit that's ever been shown to routine suction. So we don't recommend routine nasal, oral, oropharyngeal, deep, or tracheal suction for anybody, including if you have meconium-stained amniotic fluid. Even if you're not vigorous, get on with resuscitating the baby. If it turns out that you start your positive pressure ventilation and the airway appears to be obstructed, sure, go ahead and suction the airway. You may need to insert an endotracheal tube and use your meconium suction device to clear the airway. So you can't throw away those mech suckers. However, nobody gets routine suction at this point. And by doing that, we really want to encourage people to allow vigorous babies to clear their own airway, and babies that are not vigorous get started with resuscitation.
So do we still get Mr. SOPA and not Mr. OPA? Is that right?
You still get Mr. SOPA, and actually the S in Mr. SOPA may be even more important now that we're not doing routine suction, because now the idea is apply suction thoughtfully. If a baby has what appears to be an obstructed airway, if you started assisted ventilation and you can't get the chest to move or the baby to improve, go ahead and suction. And as you mentioned, Mr. SOPA, I'll say now, one of the other changes in 9th edition is it's not quite as prescriptive that you follow the exact Mr. SOPA steps in that order. We're going to allow resuscitators to use their assessment and judgment to figure out which of those steps you need to do and in which order, so that you get to have a little more flexibility with Mr. SOPA now. So, maybe it's going to be Mr. OPA, or even the increase in pressure may come early if you assess that, look, you've got a great seal, head position is perfect, I don't need to remove the mask. What I need to do right now is to increase pressure. Sure, go ahead and do that.
Mr. POSA? Anyway.
Yeah, it could be anything. It's just a little memory tool to help remember options, but it's not so prescriptive in 9th edition.
And it seems like the materials supporting the NRP just keep getting better with the addition of online simulations and some self-paced learning. When it comes to the product overall, how are you using technology to adapt it to learners' needs?
Oh, great question. There are a number of things now. So again, as you mentioned, there's a tremendous amount of online material now. The cognitive assessment tools are all adaptive learning. So as you do the cognitive assessments, if you're confident and you really know the material, you'll get through it very quickly. If you need more remediation, then the adaptive learning platform will help you learn, so that by the end, we want to make sure that everybody knows the material, and that's the goal of adaptive learning. There are all kinds of resources now for instructors to help do more either low fidelity or high fidelity simulation. The instructor course now is going to become an adaptive learning platform instead of just sitting listening to lectures or watching videos. Again, that moves toward adaptive learning. And so all kinds of great learning technology that makes it both more engaging to learn. And again, the goal is not to just sit down and take one of those tests with multiple choice answers and get a certain number at the end. It's to make sure you've really learned the material, because having the knowledge, having the skills, that's what really counts.
Well, Gary, I am due to recertify an NRP next year, and now I'm almost looking forward to it. Do you have any last takeaways for our listeners about this program and how it's evolving?
It's been a program that's been unique since 1987. There is really nothing like it. It is the gold standard of education in the delivery room. And I'll tell you, there is nothing like being at a birth where the baby comes out gray and floppy and your team knows what to do, takes the correct steps, and the baby does great. The feeling you get when you're driving home from work that day is incredible. And of course, that's what attracted me to neonatology originally. I can still remember my very first resuscitation and seeing my senior resident and thinking, oh my God, can I do that? That's what drew me to neonatology. And still 35 years later, that's what really excites me about it. And being a part of this program, and I have been since 2004, so it's been about 20 years I've been involved with this program. Every time I teach a course, every time in the delivery room, it's still exciting, it's still rewarding, and this program is what helps learners and even old folks who have been doing this a long time continue to improve their skills.
I couldn't agree with you more, Gary. Helping a baby take their first breaths. I mean, there is nothing cooler than that. Dr. Gary Weiner, thank you so much for joining us today.
My pleasure. Thanks, Joanna. Thanks, David.
To learn more about the new 9th edition of the Neonatal Resuscitation Program, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
As you know, Christy and I just got back from a trip to our future home in Seattle, kind of checking things out and getting the lay of the land. And I got to say, it was just spectacular from start to finish. Everybody we met was so friendly and so inviting, and there was all sorts of cool stuff that we love, like hiking and farmers markets, and it was just extraordinary. And best of all, there are still edible plants and shorebirds galore, so I think I'm still going to feel at home.
I think you're going to love it, David. And since we're talking about places where we are going to live and places where we live and love, I wanted to say that I just rewatched the movie National Treasure with my kids. It's a Nicolas Cage movie where he's
I know
an
this
action
movie.
adventure. Yeah. To use national treasures as like a part of this mystery treasure seeking. And it has so much Philadelphia in it, David. So we had just like spent a weekend doing some Philadelphia tourist stuff, and then I had the kids watch it, and they thought it was like amazing that this movie had all the Philly sites.
That poster is not in the PHL airport yet because I was there early this morning, but it should be. Well, that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll bring you the November edition of First Up.
We'll talk to the associate editor of blogs for pediatrics, Dr. Rachel Moon. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.